I can't remember what else I've got here, but we've got about 25 minutes and then we're going to finish up. So I'll skip through a few probably. Bruce asked me a question, which was, why is it useful to have both polarized and non-polarized? And I haven't really dealt with that, but you do see different things. And we do sometimes, for example, have difficulty in deciding what's a furrow and what's a ridge. And I haven't even remembered to tell you that the importance of that in the melanoma story is that melanoma causes pigmentation of the ridges. And the benign pattern in the furrows is very helpful. Now, there are benign lesions that affect the ridges, but most of them, well, this is an example. So this is mainly in the furrows, and this is a dirty one, so it's easy to see what the furrows are. If you follow the furrow along, it's more pigmented in the furrow than it is on the ridge. There is some pigment on the ridge, but it's more pigmented in the furrow. So that's benign. And anyway, it's one pattern. It's all the same. There's no asymmetry of colour and structure. But sometimes you can't see those furrows and ridges, and it's very helpful to be able to find the white dots due to the sweat dots. And here's an example where switching from polarized to unpolarized can make it much easier. So suddenly those dots show up nicely. So that's one example. We've done recurrent nevus. That's benign nevus, that's melanoma. Remember, the nevus occurs within the scar, the melanoma on the edge of the scar. There's a scar along there, you probably can't even see it. And there's asymmetry of colour and structure and loss of structure. Don't want to talk about spits, it's too uncommon. I'll read. There will be more examples, hopefully, before we finish in 20 minutes, of why we use polarized and unpolarized. So what we should have learnt so far is that melanoma can be any pattern, any colour, but it's mainly structureless. The more patterns and the more colours, the more likely it is that it's melanoma. And asymmetry of structure and colour is the main thing. But we're also looking for clues to confirm that, and these are the clues. And they are listed on that nice poster of Cliff's. So I just go through these clues. So we've found a lesion that's asymmetrical in colour and structure, but we want to just check that the clues are there before we submit the patient to an excision. Eccentric structureless zones any colour, not skin coloured. So we can't include that one because it's the same as the surrounding skin. But we can include that which is not the same as the surrounding skin, or that. Eccentric, so not in the middle. So we're not looking at that, we're looking at that. They don't have to be pigmented, so you could have white. So if it's whiter than the surrounding skin, that would be not skin coloured. And it could be pink as well. Grey. The colour grey is seen in the Lichen planus-like keratosis, where you have dots right across the whole thing. But greyness in a melanocytic nevus is very, very unusual. So greyness in a melanocytic lesion is a very strong pointer towards melanoma, and a good number of melanomas have grey in them. The grey takes a little bit of practice working out what's grey, but this is grey, and this is grey. It's often a bit of a hazy thing, and you're not quite sure what you're seeing, but once you've got the hang of it, you see grey everywhere in melanoma. Blackish grey, pinkish grey, black clods or dots at the periphery. So we've had them before with the reed nevus, where they're all the way around the periphery, but in melanoma they're focal. So they could be pseudopods, or they could be just isolated clods without a stick. So a pseudopod is a clod on a stick, and a clod, but they're black. And if they're any other colour, they don't count as black. So The next clue is focal pseudopods or radial lines at the periphery. That's a bit the same as this one, but it does include things that don't quite fit into the round structures. So these are elongated structures. White lines. So there's two types of white lines. There's the inverse pattern of white lines, where it looks like a reticular pattern, but it's reticular white instead of reticular brown. And then there is another one. And this pattern, the whiteness, depends on whether you're using polarized and unpolarized. And if you have a melanoma and you look first with polarized and then unpolarized, you'll see a change. And you do not see that change with benign nevi. So hopefully I've got pictures of that. Okay, these are called short, shiny streaks. Those are previous terms no longer used. And they're orthogonal. That means they're either that way or that way. They're at 90 degrees to each other. So we have, I don't know why they are, but they are. And this white line is only seen on polarized dermoscopy. So if you have unpolarized dermoscopy, you won't see short, shiny streaks. And if you have both, they switch on and switch off. Watch carefully. Got it? So that's polarized and that's unpolarized. So it's really, really helpful because you just don't see that in a benign nevus. Thick reticular lines. Well, lines disappear in melanoma, but before they disappear, they become thicker. So these sort of angulated lines, polygonal shapes and things, very typical for certain types of melanoma. Polymorphous vessels. So benign lesions have blood vessels in. You can't always see them because there might be pigment in the way. So we only see blood vessels where the pigment has gone. So a skin-colored naevus, melanocytic naevus, a basal cell carcinoma, which is malignant, a melanotic melanoma. That's where we're going to look at blood vessels. So the benign pattern should be all the same, uniform. So the commonest pattern in a dermal nevus is short curved lines, or commas, comma pattern. But the dotted pattern is an alternative pattern. But in malignancies, we see variation. So the lines vary in thickness, and they vary in length, and they vary in shape. And the dots could be clods or coils or weird and wonderful shapes. So this is several pictures trying to show this. They're quite difficult to show up because they are usually very out of focus and difficult to see. And you can, if most of the melanoma is pigmented, you can only look for polymorphous vessels where there's no pigment in the way. But we will see different sizes of the dotted blood vessels, or we may see really weird shapes. And there may also be linear vessels. I think you can see, perhaps, if you have very good eyesight, squiggles. Parallel lines on the ridges only counts for the ridges, and these are both melanomas with pigment that is prominent on the ridges, usually this sort of pattern rather than the furrows. So the furrows here are less pigmented than the ridges. And that's I mean, you don't need that rule to know that's a melanoma because of the large size, asymmetry of colour and structure. So we've actually lost some of our white dots altogether because the lesion has been destructive and it's lost its colour. We've got grey coming in, but we've also got pigment on the ridges. So melanoma metastases can be a bit of a trick for young players. There's usually a history to say, over the last week or two, I've developed all these blue spots or red spots. Those would be the two most common colours. Black sometimes, but blue is the commonest one, and red is the second most common. So if it's red, then you see the blood vessels making the colour. Yes, this says kalos, asymmetry of colour and structure. So let's practice seeing if we can find any clues. And we can. So those are eccentric structural zones. Those are black and that's brown. We have some grey structures coming in. We have some lines coming out of the edge of the lesion. And we have some thick lines. They might be grey as well. Does this one show chaos? Yes. Less than the last. I mean, basically we're seeing lines, but the lines are very well focused. They are all lines. They've not been destroyed. And that's probably going to be a nevus. And there will be other lesions on the same patient looking like that. But there is asymmetry of structure, so then we go through this list for clues, and it's borderline. Basically, the only thing we've got is these strange thick lines. Not really enough to write home about. So this would be somebody where if it was a solitary lesion, the only one they had looking like that, you'd say, that's a weird mole. Should we just get rid of it so we don't need to worry about it? And then excision would be the right thing. But much more likely, you'll find the patient has 10 or 12 moles looking like this. Watching is what's to do. So again, flat borderline lesions. If you've got similar lesions, that's the usual thing. Tell the person to examine their own skin, give them the instructions how to do that, and book them in to check from time to time. If it's only one lesion, you don't want to book them in to check them from time to time. Well, at least it seems a bit silly. You've either got to excise it, refer it, or if you're still a bit concerned, maybe just check once, and if it changes, cut it out. Leave this one to me. It's what I do for a living. This has got chaos, asymmetry of colour and structure, so we're going to cut it out with what margin? Yes, it's got clues. We've got grey structures. That's all we need. We only need one clue to say that off that comes. We've got several clues, but we only need one. This is a pigmented lesion on the sole of the foot. Does it show asymmetry of colour and structure? Yes. And so this is a melanoma on the sole of the foot. And again, if we look, we find that the pigmentation is more prominent on the ridges than it is. Right. That's a ZK. So seborrheic keratosis versus melanoma. They're both chaotic. The clues to seborrheic keratosis can be tricky. In this case, it was an irritated seborrheic keratosis, so it does have eccentric structureless areas. There is radial streaming, and there are polymorphous vessels. So even though it's a seborrheic keratosis, it has chaos and clues. But another reason for polarized and unpolarized is the seborrheic keratosis shows up different structures on polarized versus unpolarized. And this greyish colour is across the whole lesion. We're not seeing those orthogonal white lines. But sometimes ZK have to come off too.
What do you think about that sort of lesion being anaesthetised and then curetted? It all comes off very easily with curetted.
If you got a good, if you're taking it off because you think, oh, I don't want to miss the melanoma, make sure that there's a nice single sample for so a really good shave, because curettings tend to be really scrappy. So maybe using a derma blade, which is a special blade, or just a number 10 blade, and just slicing it horizontally, and then you can curette the base, so the pathologist gets a nice specimen.
But the curette won't remove anything other than seborrheic keratosis.
Basal cell carcinoma, it does quite nicely.
But the normal skin curette is sharp if it's a raised lesion. It just doesn't.
BCCs come off very nicely with curettes.
I don't push that out.
Yours is really blunt. You need a new one. No, we would use curetting much more. Well, I'm in the public service, so we wouldn't remove SEB-Ks, but yeah, I'm with you for that. But that's a separate thing. So here's a melanoma. This changes. Not quite so easy to see, but you see those white lines that we're seeing on the polarized view, and how they disappear on the unpolarized view. Seborrheic keratosis. Here we've got that cerebriform pattern that I mentioned before. If you see that, you know it's SEB-K. It's actually a single pattern. The whole lesion has that. So they're not difficult to distinguish.
So what do you need to put on the 2Ks to be able to look at them from contact? You've got the device.
You mean if you're using fluid? You can use any fluid, but I use Steri-Gel because it's sitting on my desk anyway. You could use the fluid from tear-off alcohol. You could use water. You could use oil. Oil was the traditional, but oil's quite messy. So not many people. We actually have sprays in our rooms as well with methylated spirits. We just squirt with the spray. That works quite well.
So is water okay, is it?
Well, water's not very satisfactory because it drips off. It's the alcohol's better because it stays where you put it. What do you use, Julie? Alcohol spray?
Just
Wipes, gel?
gel.
Yeah, see. Alcohol. Alcohol's good because it disappears very fast. You don't have to clean it off. It's antiseptic. It's readily available. So here's different patterns of seborrheic keratosis, but these thick, curved lines, mostly. Another reason for using the polarized versus unpolarized, again, is in seborrheic keratosis. So we've shown how lines come up with the polarized view on melanoma. But milia-like cysts, which are white or yellow clods, show up nicely in seborrheic keratosis, and they're not seen in melanoma. So here we have these little white things, and here we don't. Now that's photographing the same lesion on the same occasion without and with polarization. So the lights come on, that's a SEB-K. And you don't see that with anything else.
So say again,
So it's one of the reasons why I'm very keen on using instruments that have both. Is seborrheic keratosis are really common, and they are sometimes quite difficult to be certain that they're not melanomas. And seeing this lights coming on is really, really helpful.
So with the non-polarized,
In this case, it's the non-polarized, the lights come on. So here's an example. These are two very irregular lesions. But this one has got the white unpolarized structures. And even though it looks absolutely awful, it's a benign seborrheic keratosis. So I talked about lichen planus-like keratosis causing grey dots. So this was the original lesion, solar lentigo, goes through grey dots and then it disappears. But you can see grey dots in melanoma. So grey dots are either melanoma or they're the lichen planus-like keratosis. But if they're the lichen planus-like keratosis, they're everywhere. If they're a melanoma, they're just going to be a few here and there in little clusters. You see them in the dirty dishwater of BCC.
How long does that keratosis take to disappear?
6 months to 2 years. Dermatofibroma we've talked about. Ink spot lentigo you should be familiar with. BCCs. So the chaos and clue rules for BCCs that are pigmented are the same. Chaos, irregular colour and structure. Eccentric structural zones, grey colours. Dots and clods at the periphery, but they're not black this time. And white lines and polymorphous vessels. So this is a pigmented BCC. The pigment goes out to the edge. We've got the branched red lines. Doesn't matter if you thought it was a melanoma because it's asymmetrical in colour and structure. You're going to cut it out. What's the border for a BCC? I said it's 2 millimetres you're cutting out of melanoma. What about if it's a BCC? What border should we give that of normal? 3 millimetres? Any change on that? We would say 4 would be a more common result in our department. Sometimes we'll go for 3 if it's got a very clear border. But BCCs often don't have a very clear border, in which case we'll give it a wider margin, 4 millimetres. So, you thought this was a melanoma, and you've given it a 2 millimetre margin. What now? Do we have to go back and take it out again?
Check that's not lesions.
Was that completely excised?
Perfect. Good answers. So if you've completely excised it, you don't need to worry. There's no further surgery needed. So it's not the end of the world. But of course, if you incompletely excise a BCC, then it does need to be done again. Because this, you're not given quite a lot.
Sorry, can I just ask, if it did need to be re-excised, would you then do 4 millimetres from the original excision, or would you do more to make sure that you're not?
It would depend on the circumstances. You have to get your dermatoscope out, and if you can't find the margin, send them to somebody who can. A Mohs surgeon. They look with a microscope to find the margins. So I was just wanted to talk about monitoring. So we've already said that monitoring isn't a good idea for a solitary lesion forever. You monitor it once, really, and if it's changed, off it comes. Now, if there are some reasons why you might continue to monitor it, but mostly you would say it hasn't changed, it's fine, off you go, bye-bye. When we will monitor is in older people who are at greater risk of melanoma and where they've got multiple lesions of concern, when monitoring is the right thing to do, and we should be seen at intervals for a full skin examination and training them in self-skin examination. So it's a good idea to monitor this one because it had that peripheral pattern of growth, and we wanted to make sure that it didn't become dodgy. Now it's still the same lesion. It hasn't become a melanoma. It's just grown and changed a bit. And that was excised and I think was benign. This one is a nodule. It's a bump. It's quite small, only 4 or 5 millimetres. You get out your dermatoscope. It's got the white lines on polarised dermoscopy. It's irregular in colour and structure. That's a melanoma. It's a thick one. So how do we do it? Short-term photography. Long-term, if they've got lots of moles, send them to somebody else to do mole mapping. Digital dermoscopy is basically taking the word mole mapping means you write a map and stick a point on where the mole is. So we can say that on this mannequin, the mole is there, and that's the mapping part of it. And here's a macro and dermoscopic view. All right, so now we come to the final bit of this presentation. You saw the last 30 slides in about 3 minutes flat. Shout them out. Lesion 1 is B for melanoma because it has asymmetry of colour and structure. 2, B is C, seborrheic keratosis. It has curved, thick lines and a sharp border. 3, blue nevus is A, benign melanocytic nevus. Good. Uniform structureless blue. Lesion 4, A, melanocytic nevus. It's a bit structureless in the middle, but it has that pigment network or reticular pattern around the edge. So it's got 2 patterns, the outside pattern and the inside pattern, and they're symmetrical, so it's benign. Lesion 5, basal cell carcinoma, D, because we have asymmetry of colour and structure, and we have branched, well, they're not all that branched, but thick red lines.
Yeah.
6, B for melanoma. It's a very thin melanoma. It'll be a melanoma in situ. Still got some lines. They're thickened lines, but it's basically epidermal melanoma, irregular in colour and structure. Lesion 7. It's actually It's A, but what it is that I don't know if you can see, and you probably can't. This is a recurrent nevus, but it's a trick one. This is A. It's a collision of two nevi. So you've got the reticular nevus has bumped into structureless nevus. Just to be tricky. This one? No, it's A. It's a benign nevus. It's one of those bumpy papillomatous nevi. We're seeing basically a symmetry of structure. So it might be ugly, but it has symmetry. Congenital nevus. This one? Okay, let's have white cards for benign and orange cards for malignant, and see what we come up with. I'm hoping half and half. Okay, so we may, okay, that's about right. If you're not sure, excise it. So if chaos, look for clues. If clues, cut it out. Thank you.